imaging of uterine masses, in particular the tumors. And you know that we have a lot of imaging modalities for the diagnosis, starting from the plain film, the ultrasound, of course, the CT and MRI. Then our main concern will be in particular for MR imaging, but these are some of the facts that we should follow whenever we are going to have a CT scan of the pelvis. Number one is to ensure adequate opacification of the bowel loops by oral contrast material. Then in many times we should have intravenous injection of contrast. And one of the good policies is to have this 2D sagittal and the coronal reformatted images. The issues we would like to discuss is some of the anatomic details and techniques of examination, imaging of uterine leiomyomas and adenomyosis, endometrial carcinoma, uterine sarcoma, uterine lymphoma, and finally uterine metastasis. This is just a quick review of the anatomy of the pelvis by CT after oral and intravenous administration of contrast material. At the level of the iliac crest, see only bowel loops and some of the vessels and the iliopsoas muscle. And going into the pelvis, first you will meet the fundus of the uterus, then you will see some part of the urinary bladder, and lower down you can see the uterine cervix, which is located between the rectum and the urinary bladder. And many times you can see the ovaries by CT, which are better delineated, of course, by MRI. This is the left ovary and this is the right one. And lower down you reach the vaginal vault. This is the urinary bladder and the rectum. And here is the vault of the vagina. And you should know that CT is not that good for evaluation of uterine pathology, especially those which are concerned with the zonal anatomy of the uterus, since even after injection of contrast material and you have the reformatted images, you are not able in many times to differentiate the uterine zonal anatomy and be sure about the presence of definitive masses. But actually MRI has a good role, and ultrasound, especially the transvaginal one, may be of great help in this domain. In the MRI, we use one of the dedicated coils for evaluation of the pelvis. We do not need the special preparations, but sometimes we give a spasmolytic agent to inhibit the bowel motion to limit the artifacts, motion artifacts. And sometimes whenever we are concerned about cervical pathology, we may insert a vaginal tampon, which may distend the vagina and enable adequate evaluation of the cervical canal. Then one of the most important pulse sequences in MRI of the female pelvis is to have the sagittal T2 weighted images, which are very, very helpful in delineation of the anatomy and pathology. And many times we should have also some stair sequences in the axial oblique images, which are aligned to perpendicular to the axis of the uterus whenever we are intending to evaluate especially this part of the uterus, which is the cervical canal. And it's a good policy to have some scans for the abdomen, searching for, let us say, metastatic deposits, lymphadenopathy. And whenever you are dealing with the uterine congenital anomalies, it is also one of the helpful ideas is to look for renal anomalies as well. And this is the size of the normal uterus, which ranges from 6 to 9 centimeter long. And this is the weight of the uterus. And most of the uterus is covered by endometrium, as you can see here. And this is a sagittal T2 weighted image, which presents very nicely the zonal anatomy of the uterus. Here is the endometrium, the junctional zone, and the myometrium. Actually, the position of the uterus is not that of much interest, but many times you can see the uterus which is retroverted, like this one, and there are some degrees of retroversion, as you know. By CT, you cannot identify the zonal anatomy. You see the uterus as a solid soft tissue mass at its anatomic location, but by MRI you can see this. And one of the important items here is to look for the thickness of the junctional zone, which is also helpful in diagnosis of some uterine pathology, especially the adenomyosis. When you see that the thickness of the junctional zone, this is the junctional zone, which should not exceed 5 millimeter. If it is more than 12 millimeter, you are sure that you are dealing with uterine adenomyosis. And by the age of menopause, then you see that there is some loss of the uterine volume and loss of definition between the zonal anatomy. And you see atrophic endometrium and the more hypo-intensity of the myometrium, and the junctional zone is not that well delineated. Uterine fibroids are the most common benign lesion affecting the uterus, and the incidence range is between 25 and 50%. 10% of leiomyomas can affect the cervix, and it is more common in nulliparous women, this tumor, and it is well known to all of us by its characteristic radiologic and imaging criteria. First, we can diagnose uterine fibroid just from the plain film by identifying a calcified mass in the female pelvis. Then the most likely diagnosis is calcified uterine fibroid. The presentations are usually by vaginal bleeding, and the bleeding may lead to anemia. And of course, if it is sizable, it will produce pressure symptoms in the urinary bladder and the rectum. By hysterosalpingography, you see either filling defect inside the uterine cavity, or you see markedly distorted uterine cavity by the presence of multiple fibroids. By ultrasound, the fibroid mass is usually hypoechoic, as you can see here, and if you use Doppler facility, you can see some vascularity within the lesion. By CT, the uterine fibroid is almost similar to the density of the uterus, and you can diagnose fibroid uterus by the presence of mere enlargement of the uterus, lobulated outline, the presence of some calcification, and here this is the endometrial cavity, and we see a uterine fibroid which is minimally hypodense compared to the enhancing myometrium, and the presence of calcification will support to some extent the diagnosis of fibroid. And this is the big fibroid mass in the uterus. This is the right ovary, and you know that there are a lot of types of degeneration that can affect the fibroid mass, starting by myxoid degeneration and hyaline degeneration and hemorrhagic degeneration, cystic changes, and so on. Then by MRI, fibroid mass is a well delineated mass lesion, either in the cavity of the uterus or inside the myometrium or in the subserosal area. Characteristically, the mass is of low signal in the T1 and T2 weighted images, and if you inject contrast material, the mass will not enhance as similar as to the enhancing normal myometrium. And you all know that MRI is less sensitive or insensitive for detection of calcium in uterine fibroids. And this is T1 and this is T2, and this is T1 post contrast of a big subserosal fibroid affecting the uterine fundus. And whenever the leiomyomas affect almost the entire myometrium, and then this is known as uterine leiomyomatosis. And you can easily appreciate some of the normally appearing fibroids of low signal, and some others who undergone degeneration. And this is an axial image showing the uterus with multiple fibroids, a submucous one inside the lumen and multiple within the wall. You all know that one of the treatment choices for leiomyomas, especially in reproductive period and also whenever they are huge, is to do uterine artery embolization. And this is a big fibroid mass, and this is the vascularity, and here is a fibroid mass. And 6 months after embolization, and you can appreciate the shrinkage in the side. And this is before embolization, and this is after embolization. You can see marked decrease in the blood supply of the mass. And this is what I'm said, that if the uterus is totally involved by fibroids, and you can say that this is uterine leiomyomatosis. Then we came to the adenomyosis, which is not a neoplastic condition. It entails that there is some of the endometrium that has dislocated inside the myometrium. And this will result, of course, in marked thickening of the junctional zone. And there are many characteristics for adenomyosis, especially these bright spots within the affected myometrium, which may represent heterotopic endometrium or cystic changes or hemorrhagic foci. They are delineated actually in the T2 weighted images. And this is the normal appearance of the uterus, and this is the uterus with adenomyosis. You can appreciate very much the thickening of the endometrium of the junctional zone. And here the presence of adenomyosis affecting the anterior part of the uterine body, and you can also see two classic fibroids. Sometimes the adenomyosis may present as a mass, and you have to discriminate this mass separable from fibroid. The only finding that help in the differential diagnosis is the definition of the margin. Uterine fibroid is usually a well-defined margin, while the adenomyosis has a diffuse margin with the adjacent myometrium. And here is the difference between adenomyoma and the leiomyoma or the fibroid. You see the well definition of the margin. Both lesions will enhance with contrast the adenomyosis and the uterine fibroid. And this is also a focal adenomyosis affecting the uterine fundus and the posterior wall, showing the classic presentations. Then we came to the endometrial carcinoma, which is considered the malignancy number 4 after the breast, the lung, and the colorectal cancers. And the lesion is usually diagnosed after menopause, and the main presentation is vaginal bleeding. And there are a lot of histologic or histopathologic types of endometrial carcinoma, but this is the most commonly seen one, which is the endometrioid adenocarcinoma, a lot of lesions, and also the carcinosarcoma is also one of the frequently seen pathologies. Here you can appreciate the factors which can increase the risk of endometrial carcinoma, and in the opposite side you can see factors which decrease the risk. And this is stated in the literature that smoking decreases the risk of endometrial carcinoma but increases the risk of cervical cancer. Then the sonography of endometrial cancer is globally non-specific, and you see there is thickening of the endometrium, there may be an endometrial mass projecting inside the uterine lumen. And it is also said in the literature that the cutoff value for accepted endometrial thickening is 5 millimeter, considering that the patient is asymptomatic, postmenopausal, and is not receiving tamoxifen. And this is a appearance of the endometrial carcinoma by ultrasound and Doppler. You see globular or lobulated mass projecting inside the uterine lumen with some vascularity on Doppler scanning. CT is the least of the imaging modalities to identify accurately the endometrial cancer, and these are the two most reliable signs. And you see that the uterus is slightly enlarged and there is hypodense lesion within the endometrial cavity. But MRI is of course the best way to assess the presence of the tumor and to assess the stage of the lesion, and also to see if there is metastatic lesions. Then the endometrial cancer is an ill-defined lesion within the endometrial cavity. It may infiltrate the wall of the uterus and may go into the adjacent organs, and the signal intensity of the tumor is usually less than that of the endometrium in T2 weighted images, but more than the signal intensity of the myometrium. And there is a well-known staging policy for the endometrial cancer, which should include, I will mention it in a moment, but actually we should have the sagittal T2 weighted images and the axial images perpendicular to the axis of the uterus, and it's very important to assess the extent of the tumor into the cervical canal. Then the staging criteria depends on if the tumor is totally confined to the endometrial cavity or has infiltrated the wall, and how much this infiltration, and also if it is extended outside the uterus. One of the good policies now is to have the dynamic study for the uterus by MRI after injecting contrast material. Then in the delayed phase, you got well delineation of the tumor against the enhancing myometrium. Then you can appreciate very easily how the tumor is infiltrating the thickness of the myometrium. And this is the staging classification of uterine cancer. And this is an old one, but nowadays they consider that stage 1A is the tumor which involves less than half of the myometrial thickening, and it's stage 1B more than half of the myometrial thickening. An extension to the cervix is considered the stage 2. Extension to the nodes or other organs except the urinary bladder and the rectum is stage 3. Invasion of the rectum or the urinary bladder or distant metastasis is considered stage 4. And this is the stage 1A uterine endometrial cancer, where you see the mass inside the uterine cavity and the uterine wall is more or less intact. And this is also one of the helpful criteria, which is the use of diffusion weighted images by MRI to help you to appreciate how much of the endometrium has been involved. And in this lesion, you may say that this is stage 1A because of less than half of the myometrium has been involved, and this is the diffusion weighted image and the ADC map, and you can see that most of the thickness of the myometrium has been infiltrated. And this is the classic appearance of uterine endometrial cancer invading the myometrium. And this is the way how to evaluate the lesion after injection of contrast material. The delayed images are very helpful in this domain. Then distension of the uterine cavity by the tumor mass may be an obstacle to assess accurately the degree of endometrial invasion in some cases. And here stage 2, because there is involvement of the uterine cervix beside the tumor in the uterine fundus. And this is stage 3B because the lesion has extended into the vault of the vagina, and you can appreciate the tumor involving the cervix as well as the proximal part of the vagina. Then stage 3 also is the presence of metastatic lymph nodes, which is one of the criteria of stage 3 endometrial cancer whenever you detect metastatic lymphadenopathy. And in this lesion, you can feel that the tumor is totally confined to the uterus, but at surgery there was peritoneal deposits, ovarian deposits, and deposits within the intestine as well, and this is considered the stage 4B. Also, in cases of after menopause, you know that the discrimination between the zonal zone, the injunctional zone, and the myometrium is lost, and it's difficult to appreciate the invasion. But in this case, you see some invasion of the myometrium and metastatic lung deposits, meaning that you are dealing with stage 4B uterine carcinoma. Actually, there are some pitfalls in the diagnosis, including that thickening of the endometrium for benign disease or hyperplasia. Very small tumor size may be also overlooked, and in the postmenopausal woman, you cannot appreciate very much the degree of myometrial invasion. A stretching of the wall of the uterus may be an obstacle to assess the early stages of the tumor, and concomitant benign disease like fibroid or adenomyosis may be an obstacle also. Then this is an endometrial cancer after in a female 90 years old, and you can appreciate the tumor. This is T2 weighted image, but you cannot say for sure how much of the myometrial invasion is. And by the enhancement, then you can appreciate the tumor separable from the enhancing myometrium. Lymph nodes have the criteria of size, as you all know, and they may be mistaken for adnexal structures, bowel loops, or peritoneal deposits. And this is the differential diagnosis of an of a mass inside the endometrial cavity. Either it may represent an endometrial polyp, or leiomyoma, or adenomyoma, or endometrial hyperplasia, or blood clots, and retain the products of conception, and also you consider the possibility of endometrial cancer. Endometrial polyps are usually benign. They are commonly seen in patients receiving tamoxifen, and they are actually located near the uterine fundus and near the cornea of the fallopian tubes. In 20% of the patients, they are multiple, and the appearance is not that specific on ultrasound and MRI. You see a mass inside the endometrial cavity. In the literature, they say that if on MRI you detect a central hypointense fibrous core, this may help you to justify the possibility of an endometrial polyp. But actually, we need the biopsy and the keratocyst to be sure that you are dealing with endometrial polyp, not an endometrial cancer. And this is a uterus involved by many fibroids, and you can see inside the uterine cavity an endometrial polyp. They said that this polyp is usually not enhancing. It has a smooth margin, and of course, it does not invade the adjacent myometrium. Then we came to the uterine sarcoma, which is considered representing 1% of the genital malignancies and about 3 to 7% of uterine malignancies. There are many types of sarcomas. The most common one is leiomyosarcoma, which is malignant degeneration on top of a pre-existing fibroid. And this carcinosarcoma, which is one of the commonly seen histopathologic findings in endometrial cancer. The diagnosis of uterine sarcoma depends on two main criteria. Number one is a huge enlargement of the uterine cavity in most of the cases, and the presence of extensive necrosis, hemorrhage, and calcific foci. And you can see here, this is the uterus, which is infiltrated by leiomyosarcoma. Leiomyosarcoma in the uterus is considered the most common leiomyosarcoma all over the body. And this is another example. And this is the third example of leiomyosarcoma of the uterine wall, significantly encroaching on the uterine cavity. The lymphoma of the uterus is seen in about 1% of patients with known to have lymphoma. They have lymphoma of the uterus. And at autopsy, this percentage is very high, and you can identify lymphoma of the uterus in about 40 to 50% in patients with lymphoma. The imaging finds are not specific, But they say that if you see that the uterus is diffusely enlarged and the endometrial lining as well as the junctional zone are more or less preserved, you may think of this. And this is an example. You see diffuse uterine enlargement, and then the T2 weighted image. This is not, of course, fibroid, and you can see the preservation of the endometrial cavity to some extent, and this was proved to be a B-cell lymphoma. And this is another case of lymphoma affecting the uterus, affecting the ovaries, and this is one of the helpful landmarks is the detection of bulky homogeneously enhancing retroperitoneal lymph nodes. Metastases are very rare to the uterus, and they are not usually diagnosed by imaging. They are diagnosed during curettage and sampling. Metastases can go to the uterus from extrauterine lesions, and also they may reach the uterus by hematogenous spread and also the lymphatic spread. And thank you very much.